All right, let's get right into it. If you're an anesthesiast, you know that managing patients with cancer is getting more and more complex. So today we're going to do a really high-yield review of the anesthetic implications for patients who've had these modern neoadjuvant cancer therapies before they even get to surgery. This is absolutely essential stuff, not just for your day-to-day practice, but for your exams too.
The central challenge for us is this weird paradox. The very treatments that are shrinking tumors and literally saving lives, we're talking chemotherapy, immunotherapy, radiotherapy, they also leave behind what I like to call a toxic footprint. See, they don't just target cancer cells, they hit healthy cells too. And that's where we come in. Our job is to understand that footprint, to anticipate the risks, and to get our patients safely through their surgery.
So, here's our game plan. First, we'll set the scene and define the challenge. Then, we're going to take a deep system-by-system dive into the toxic effects of chemotherapy. After that, we'll tackle the newer kids on the block, immuno and radiotherapy. Then we'll talk preoperative strategy, and finally, we'll wrap it all up into a kind of intraoperative playbook.
Okay, let's set the stage. Why is this such a big deal for us now in modern anesthetic practice? Well, it all starts with really understanding what we're talking about when we say neoadjuvant therapy. Think of neoadjuvant therapy as the opening act before the main event, which is usually surgery, and has two really powerful goals. First, you want to shrink that primary tumor, right? Make it way easier for the surgeon to get it all out. And second, you want to hunt down and destroy any potential micrometastases. Those are tiny little cancer cells that might have already spread but are just too small to see on a scan. It's a fantastic strategy, but it means the patient who rolls into our operating room is a whole different physiological beast.
So what's really useful is how we can almost map out these risks. Let's get to the core of this whole thing and build a mental model of chemotherapy's toxic footprint, looking at each organ system one by one.
Cardiotoxicity is without a doubt one of the most common and most serious side effects. The word you've got to remember here is irreversible. Just look at the anthracyclines like doxorubicin. They can cause a chronic, progressive cardiomyopathy. And they're not alone. 5-FU can cause coronary artery spasm leading to ischemia. Platinum compounds like cisplatin, they're linked to heart failure and AFib. And then you have others like arsenic trioxide that can prolong the QT interval, setting the stage for torsades de pointes. It's a minefield.
So how do we find this stuff before it becomes a catastrophe? You have to be systematic. Start with a really focused history. Ask about any new signs of heart failure. A 12-lead ECG is an absolute must. You're hunting for arrhythmias or QT changes. Then labs like troponins and NT-proBNP can give you some big clues. And look, if you have any suspicion at all, an echocardiogram to check their LV function is the next step. If things look dicey, get a cardiology consult to help optimize them.
All right, let's switch gears to the lungs. A bunch of these agents can cause pulmonary toxicity, and it's tricky because the symptoms are so vague. A dry cough, shortness of breath, some hypoxemia. Now here's the key clinical pearl. Chemotherapy-induced lung toxicity is a diagnosis of exclusion. You have to be sure it's not an infection, not METs, not a PE. And as you can see, the damage can range from that life-threatening fibrosis with bleomycin all the way to ARDS or pneumonitis with the others.
Okay, if there is one drug you burn into your memory for your exams, it's this one, bleomycin. It's often used for things like germ cell tumors and Hodgkin's disease. And here is the absolute key takeaway. The risk of oxygen-induced lung injury is permanent. It's a lifelong risk. It doesn't matter if they had it last month or 20 years ago. Any patient who has ever had bleomycin is high risk, period.
So, what does that mean for us in the operating room? It means we need a very, very specific oxygen strategy. You have to avoid high concentrations of inspired oxygen like the plague. The goal is to carefully titrate your FiO2 down to the absolute minimum you need to keep their SATs between 88 and 92%. This is not a suggestion, it's a rule. And of course, you pair this with lung protective ventilation and the right amount of PEEP to get the job done safely. And just real quick, let's touch on the kidneys and liver. Again, it's all about specific drugs hitting specific targets. Cisplatin is notorious for being nephrotoxic. It can cause AKI and drop the GFR. Ifosfamide can cause a specific type of proximal tubular damage called Fanconi syndrome. And over in the liver, 5-FU can lead to a fatty liver or steatosis, while oxaliplatin is known to cause hepatic sinusoidal injury. So obviously getting a preoperative GFR and a set of LFTs is a must. Okay, so that's the classic chemo world, but the landscape is changing, and it's changing fast. We're seeing way more patients getting newer treatments, like immunotherapy and super precise radiotherapy.
And believe me, they bring a whole new set of challenges to the table. Immunotherapies, especially the ones called immune checkpoint inhibitors, or ICIs, work in a really cool way. They basically take the brakes off the patient's own immune system so it can attack the cancer. The problem? That revved up immune system can start attacking healthy tissue too. We call these immune-related adverse events, and they can happen anywhere. We're talking endocrinopathies like adrenal insufficiency, myocarditis and pericarditis in the heart, or even a life-threatening pneumonitis in the lungs. A really important point here is that these patients might be on high-dose steroids, so they're going to need a perioperative stress dose. And that brings us to radiotherapy. I'm just going to read this quote because it says it all. The anesthesiologist needs to be aware of difficulties with airway management in patients treated with radiotherapy for head and neck cancers. That is probably the biggest understatement. For any patient who's had radiation to the head and neck, you shouldn't just anticipate a difficult airway, you should expect one. And this slide shows you exactly why. Radiation just wreaks havoc on the anatomy. You get fibrosis of all the soft tissues, which makes everything stiff and unyielding. You get trismus, where they can barely open their mouth. You can get edema of the glottis. Their neck mobility goes way down. You can even get osteonecrosis of the jaw. Every single one of these things makes mask ventilation harder, laryngoscopy harder, and intubation harder. A meticulous preoperative airway plan, which might include an awake fiber optic intubation, is absolutely essential.
Okay, we've laid out all the major risks, we know the potential landmines, so let's pivot now to the practical side of things. How do we take all this knowledge and use it to set our patients up for success before they ever see the inside of an operating room?
So, with all these potential hits to their organ systems, getting the patient ready for the huge physiologic stress of surgery is just paramount. The whole strategy really boils down to two big ideas: prehabilitation and timing. Prehabilitation is all about getting ahead of the game. It's about proactively improving a patient's functional state before surgery. And the best way to do it is with a multimodal approach built on 3 pillars. First, nutritional support. These patients are often malnourished. Second, psychological help to reduce their anxiety and just get them mentally prepared. And third, and this is a big one, structured exercise training to boost their cardiopulmonary fitness. Timing is also absolutely critical. It's a balancing act, right? We need to give them enough time to recover from the acute toxicity of their treatment, but we can't wait so long that the cancer starts to progress again. The evidence seems to point to a sweet spot. That 4 to 6 week interval after therapy seems to be optimal. And for those of you studying, you should know the NEO-RES-2 trial. It looked at esophageal cancer and basically showed that waiting longer than that didn't provide any short-term benefit.
All right, we've assessed them, we've optimized them. Now it is showtime. Let's pull everything we've talked about together into a clear, actionable, intraoperative playbook. Here are the golden rules. Always use lung protective ventilation. If your patient had cardiotoxic drugs, you should seriously consider invasive monitoring, like an arterial line. I know, I sound like a broken record, but you have to be prepared for a difficult airway after head and neck radiation. Also, remember a lot of these patients have bone marrow suppression, pancytopenia, which means a higher risk of bleeding and infection. And because they're immunocompromised, have a really low threshold to use leukocyte-reduced and irradiated blood if they need a transfusion.
One final kind of nuanced point. You've probably heard the debates about whether regional is better than general anesthesia, or if TIVA, total intravenous anesthesia, is better than using volatile gases for long-term cancer survival. The bottom line, for now, is that while this is a super important area of research, the jury's still out. We just don't have a consensus yet on what the optimal anesthetic technique is to improve those long-term outcomes.
And that kind of leaves us with a final thought to chew on. Everything we've covered is the landscape as it stands today. But, the pace of change in oncology is just staggering. So the real question for all of us is this. As these cancer therapies continue to evolve and get more complex, how do we, as perioperative physicians, make sure we evolve right along with them? This whole explainer was based on 2 fantastic review articles, one from BGA Education and the other from Continuing Education in Anesthesiology, Critical Care, and Pain. If you really want to dig into the details, I highly recommend you check them out. Thanks so much for tuning in.